In this sketch, we'll talk about the 4 main glycogen storage diseases. Sounds scary, right? Well, step right this way and find out. Welcome, ladies and gentlemen. Gather around so I can tell you a story about an eccentric man named Sir Earl McArdle who built a gaudy castle over a sacred site a long time ago, against the wishes of his advisors. As soon as they moved in, the McArdle family encountered some, unfortunate events, including a strange house fire that resulted in the disappearance of several family members. While McArdle is long gone now, his loyal butler claims the disembodied spirits of the McArdle family control the premises, and that the castle is cursed. But before we begin to tour this cursed castle, who dropped their sketchy land pass? Anyone? No? And just a heads up, all of the glycogen storage diseases that we'll talk about are autosomal recessive. Okay, let's first meet the butler, Sir von Gierke, and tour the kitchen.
Boys and girls, let me tell you, when I grew up,
Hey, we're gonna have to cut you short because we're kind of on a time crunch here. Anyways, von Gierke disease, or type 1 GSD, is the most common glycogen storage disease. It's caused by a deficiency of glucose-6-phosphatase. This enzyme turns G6P back to glucose, so the liver can release it into the bloodstream. How will you remember this enzyme? Hey, stop pulling the P batteries out, you rapscallion! What is up with the phosphatase kids these days?
Back in my day.
And we're back. The inheritance for von Gierke disease, like every other glycogen storage disease that we'll talk about in this sketch, is autosomal recessive. Now on to the clinical presentation. Onset is sometime between 3 to 6 months after birth. One of the classic findings is fasting hypoglycemia, since the liver depends on glucose-6-phosphatase to make glucose via gluconeogenesis and glycogenolysis. So anyone with von Gierke disease can't go a day without eating because their liver won't be able to maintain a normal blood sugar. Aw, poor scaredy cat dropped his candy. That's too bad. Another consequence is that these patients can't completely break down glycogen. Therefore, it accumulates in the liver and kidneys, leading to hepatomegaly and renomegaly. Whoa, kids! Check out the giant liver and kidney. Delicious. Bon appetit! Since these patients can't make glucose from non-carbohydrates and can't fully break down glycogen, they'll have to rely on anaerobic glycolysis for energy during a fast. And that's not good at all because it's not sustainable, and one of the products, lactate, will be elevated in the blood, possibly resulting in lactic acidosis. Ew, who left the spoiled milk out? Von Gierke? I'm looking at you. Besides elevated lactate, these patients will also have hyperlipidemia and hypertriglyceridemia. Looks like von Gierke is trying to share some food with us. I think we're gonna pass, sir. The trident is our recurring symbol for triglycerides. Hyperuricemia is another finding caused by reduced renal clearance and increased degradation of adenine nucleotides. We'll represent this uric acid buildup with our recurring symbol of yellow yarn, and the knitting needle stabbed painfully into the ball of yarn as gout. Hyperlipidemia in these patients may lead to tendon xanthomas, or yellow lipid deposits in the hands, heels, and feet. Elevated triglyceride levels can also cause acute pancreatitis. Anyone care for some flambéed pancreas? Other findings are significant renal impairment leading to proteinuria, hematuria, and nephrocalcinosis. Looks like our lovely butler spilled some chicken. Do you want me to just order a pizza, sir? How do we treat von Gierke disease? Frequent feeding with oral glucose and cornstarch is absolutely critical to prevent fasting hypoglycemia and the associated consequences. The don't touch sign next to the rotting fruit inside the galaxy bowl will help you remember that these patients should also avoid fructose and galactose, because converting fructose and galactose into glucose requires glucose-6-phosphatase. Okay, let's move on to the second glycogen storage disease, Pompe. Well, that was pretty freaking scary, but here lies Pompe. Yeah, it's just a painting, nothing to worry about. Unlike the other diseases on our tour, Pompe disease, aka type 2 GSD, results from a deficiency of a lysosomal enzyme. The key word here is lysosomal. Remember that lysosomes remove waste inside cells, kind of like a trash can. Specifically, Pompe disease is caused by a deficiency of lysosomal acid alpha-1,4-glucosidase. Patients will usually start having symptoms in the first few months of life. Wait, is that a ghost? Don't worry, kids. He's got a huge heart. He won't bite you. Or at least that's what we thought until last week when one of the kids had to get vaccinated against ghost rabies. Yeah, ghost rabies. It's real. Look it up. Don't look it up. Pompe disease classically affects the heart. Glycogen accumulates in the heart, causing cardiomegaly and cardiomyopathy, and liver, causing hepatomegaly. These patients may also have a large tongue. This form of the disease typically presents in infants. Infants with Pompe disease may also present with hypotonia, represented by this droopy spirit. The juvenile/adult form of Pompe disease is associated with myopathy, which can lead to respiratory failure. Dang, these ghosts seem scary at first, but now I just kind of want to take care of them. As you can probably guess, when your heart and muscles are weak, then exercising would be super difficult. Unfortunately, these patients present with exercise intolerance and early death. On labs, you'll see an elevated creatine kinase and normal blood glucose, represented by the kid holding a bucket of crispy chicken and a bag of candy. Muscle biopsy would show accumulation of glycogen in lysosomes. Just don't start poking these ghosts. Let's move on to Cori disease, aka type 3 GSD. Look outside the window to see McArdle's creepy corgi dog. Aw, who's your good boy? Cori disease is caused by a deficiency in the glycogen debranching enzymes alpha-1,6-glucosidase and 4-alpha-D-glucanotransferase. Oh my gosh, watch out! That tree branch just fell out of nowhere! Here, Corgi, did you cause this? The heck is wrong with this dog? Generally speaking, Cori disease is a milder form of von Gierke disease, also causing cardiomyopathy, hypotonia, and hepatomegaly. Corgi, did you steal the heart out of that crypt? Bad Corgi! So, how do we differentiate it from von Gierke disease? Well, since it's the milder form, we expect the clinical findings to occur later in life. Furthermore, labs will show normal blood lactate levels, unlike von Gierke disease. The other lab findings are similar to von Gierke disease. Look for high creatine kinase and low blood glucose during fasting. Another distinguishing feature is accumulation of limit dextrins in the cytosol. And you're probably wondering what limit dextrins are. Well, they're the short chains of 2 to 4 glucose residues left on glycogen after glycogen phosphorylase has done its job. In Cori disease, these limit dextrins will accumulate inside cells because the debranching enzymes are needed to break them down. Importantly, in Cori disease, gluconeogenesis remains intact and glycogenolysis is affected, whereas in von Gierke disease, both gluconeogenesis and glycogenolysis are impaired. Okay, let's move away from the backyard because it's kinda creeping me out. Boy, I'm gonna ask for a raise soon. Come on, Ricky, be brave. All right, let's talk about the last glycogen storage disease and probably the most commonly tested aside from von Gierke disease. McArdle disease, aka type 5 glycogen storage disease. And let me present to you the star of the cursed castle, Sir Earl McArdle. Earl, do you have something to say? Hey, kid, it's okay. McArdle isn't real. Or is he? Meh, just kidding. In McArdle disease, there's a deficiency of muscle glycogen phosphorylase. The end effect of this enzyme loss is reduced capability and muscle utilization of stored glycogen, with no other systemic effects. Clinically, McArdle disease presents with painful muscle cramps during exercise. Sir McArdle, why are you cramping up? Did you go out on one of your nighttime terror strolls around Sketchyland again? You wily dog, you. There's full-on muscle breakdown along with those cramps, so patients can present with myoglobinuria, which on test day might be phrased as red urine with no RBCs present. Ew, who peed on the globe? Gross. Gosh, why do I even work here? They'll also present with irregular ECGs and possibly arrhythmias due to electrolyte abnormalities. Another important feature of McArdle disease is the second wind phenomenon, where muscle weakness improves after a short period of rest once blood flow to the affected regions increases. Remember, this is a disease of energy resources, so when the resources return, the muscle cells work fine. It's kind of drafty in here. Dang, they really need to fix these windows. Finally, as you'd expect with all this muscle damage and breakdown, patients will have an elevated creatine kinase. Blood glucose levels will be normal because the liver regulates blood sugars, and fortunately, the liver is completely intact in these patients. And just like this little kid running scared, it's time for me to make like a tree and get the hell out of Curse Castle. But not before a quick recap. The four main types of GSDs are von Gierke, Pompe, Cori, and McArdle disease. These diseases are autosomal recessive. Von Gierke disease is the most common type of GSD, and it's caused by a deficiency of glucose-6-phosphatase. Affected individuals present with fasting hypoglycemia because gluconeogenesis and glycogenolysis are impaired. Notably, these patients also have elevated lactate. Treatment is frequent feedings of oral glucose and cornstarch, avoiding fructose and galactose. Pompe disease is caused by a deficiency of lysosomal acid alpha-1,6-glucosidase. Labs will show elevated CK and normal blood glucose. Cori disease presents similarly to von Gierke disease, but symptoms are milder because gluconeogenesis is intact. It's caused by deficiency of the glycogen debranching enzymes. Labs show normal lactate, elevated CK, and low blood glucose, and limit dextrins may be seen in cells. McArdle disease is caused by a deficiency of muscle glycogen phosphorylase, and patients may experience a second wind phenomenon. Labs will show elevated CK and normal blood glucose.